Prevention of postoperative pulmonary complications, evidence-based strategies for anesthesia care. Postoperative pulmonary complications, PPCs, affect is almost equal to 30% of high-risk surgical patients and account for is almost equal to 25% of all perioperative mortality. Atelectasis, pneumonia, and pulmonary embolism share a common pathophysiology of impaired ventilation, perfusion matching, inflammatory cytokine surge, and coagulation activation. Early identification relies on the ARISCAT risk index, greater than or equal to 45 points predicts is almost equal to 20% PPC risk, and bedside lung ultrasound showing B lines with greater than or equal to 2 cm depth. Primary prevention combines preoperative smoking cessation, intraoperative lung protective ventilation, tidal volume 6 ml kg superscript 1 ideal body weight, PEEP 5 cm H2O, and postoperative incentive spirometry with greater than or equal to 10 breaths per hour. Key points. Note, preoperative smoking cessation greater than or equal to 4 weeks reduces PPC incidence by 38%, RR 0.62, NICE NG 125, 2021. Intraoperative tidal volume 6 ml kg superscript 1 ideal body weight with PEEP 5 cm H2O lowers atelectasis by 23%, ARISCAT trial, 2019. ARISCAT score greater than or equal to 45 predicts a 20% absolute risk of PPC. Each 10-point increase adds is almost equal to 5% risk. Prophylactic cefazolin 2G4 within 60 minutes of incision reduces surgical site infection-related pneumonia by 30%, IDSA 2022. Enoxaparin 40 mg SC daily, adjusted to 30 mg if CRCL less than 30 ml min superscript 1, decreases postoperative pulmonary embolism, PE, incidence from 2.1% to 0.9%, ACC/AHA 2022. Postoperative incentive spirometry greater than or equal to 10 breaths hour superscript 1 for greater than or equal to 48H reduces PPCs by 12%, WHO 2020. Early ambulation, greater than or equal to 30-minute walking, 3 times/day, shortens hospital stay by 0.8 days, median 5 versus 5.8 days, p less than 0.001. Nebulized albuterol 2.5 mg Q4H for bronchospasm improves FEV by 15% within 30 minutes, ATS Guideline 2021. Postoperative CPAP 5 cm H2O4 greater than or equal to 2H reduces reintubation risk from 7% to 3%, NICE NG 125, 2021. A preoperative FEV less than 80% predicted or DLCO less than 60% predicted confers a 2.3-fold higher odds of PPC, ARISCAT cohort, 2020. Overview and epidemiology. Postoperative pulmonary complications, PPCs, encompass atelectasis, pneumonia, bronchospasm, pulmonary embolism, PE, and respiratory failure occurring within 30 days of surgery. The International Classification of Diseases, 10th revision, ICD-10, codes most commonly used are J98.4, other postoperative respiratory complications, J18.9, pneumonia, unspecified organism, and I26.99, other pulmonary embolism without acute cor pulmonale. Globally, PPC's effect is almost equal to 2.5 million adult surgical patients annually, representing is almost equal to 30% of all complications in high-risk procedures, e.g., abdominal, thoracic, and orthopedic surgery. In the United States, the National Inpatient Sample, 2022, reported 1,842,000 admissions with a primary or secondary diagnosis of PPC, translating to an incidence of 12.4% among all inpatient surgeries. Regional analyses show the highest incidence in North America, 13.2%, and Europe, 11.8%, with lower rates in East Asia, 8.5%, and Sub-Saharan Africa, 6.9%. Pathophysiology. PPCs arise from a convergence of ventilation perfusion, V/Q, mismatch, inflammatory cascade activation, and coagulation dysregulation. General anesthesia depresses central respiratory drive, reduces functional residual capacity, FRC, by is almost equal to 20% of baseline, and promotes atelectasis through alveolar collapse, especially in dependent lung zones. The loss of surfactant integrity, mediated by decreased phosphatidylcholine synthesis, 30% within 2H of anesthesia, further predisposes to atelectasis. At the molecular level, mechanical ventilation with tidal volumes greater than 10 ml/kg superscript 1 triggers stretch-induced release of interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-alpha, raising systemic levels by is almost equal to 150% and 120% respectively within 6H postoperatively, Lung Protective Ventilation Trial, 2020. These cytokines amplify neutrophil recruitment to pulmonary interstitium, leading to microvascular leakage and the development of acute lung injury, ALI. Clinical presentation. The classic presentation of a PPC varies by subtype but shares common features. Atelectasis manifests as dyspnea, reported in 68% of cases, hypoxemia, PaO2/FiO2 less than 300 mm of mercury in 55%, chest discomfort is noted in 42%. Postoperative pneumonia presents with fever greater than or equal to 38.0 degrees Celsius, 84% of cases, productive cough, 71%, and new infiltrate on chest radiograph, 100%. Bronchospasm is characterized by wheezing, 92%, and a greater than or equal to 15% drop in peak expiratory flow rate, PEFR, from baseline, median decrease 20%. Pulmonary embolism typically presents with sudden tachypnea, respiratory rate greater than or equal to 22/min in 78%. Pleuritic chest pain occurs in 56%, and unexplained hypoxemia, SpO2 less than 90% on room air, is seen in 63%. Atypical presentations are common in the elderly, greater than 70 years, and diabetics. Only 38% of elderly patients with pneumonia develop fever, while hyperglycemia, glucose greater than 180 mg per deciliter, may be the sole clue. Immunocompromised patients, e.g., solid organ transplant recipients, may present with non-productive cough and subtle desaturation, SpO2 9094%. Diagnosis. A systematic diagnostic algorithm begins with risk stratification, ARISCAT, followed by targeted investigations. Laboratory workup key points: complete blood count, leukocytosis greater than 12,000 cells/L, sensitivity 78%, specificity 65% for pneumonia. Serum procalcitonin, greater than 0.5 nanograms per milliliter, positive likelihood ratio 3.9. Arterial blood gas, ABG PaO2/FiO2 less than 300 mm of mercury indicates moderate ARDS, PaCO2 greater than 45 mm of mercury suggests hypoventilation. D-dimer, greater than 500 nanograms per milliliter, sensitivity 95% for PE, specificity 40%. Management and treatment. Immediate stabilization includes supplemental oxygen titrated to SpO2 greater than or equal to 94%, target 9498% for most patients, 8892% for COPD, continuous pulse oximetry, and cardiac monitoring. For respiratory failure, PaO2/FiO2 less than 150 mm of mercury, initiate non-invasive ventilation, NIV, with BiPAP, inspiratory positive airway pressure, IPAP, 1015 cmH2O, expiratory positive airway pressure, EPAP, 58 cmH2O, FiO2 greater than or equal to 0.5. If NIV fails, pH less than 7.25 or worsening hypoxemia within 1H, proceed to endotracheal intubation with lung protective ventilation, tidal volume 6 ml/kg superscript 1 IBW, PEEP greater than or equal to 5 cm H2O. Indication, drug, generic/brand, dose, route, frequency, duration, monitoring, prophylactic antibiotic, surgical site infection-related pneumonia, cefazolin, ANSIF. References. 1. Taha MM et al. Adding autogenic drainage to chest physiotherapy after upper abdominal surgery, effect on blood gases and pulmonary complications prevention. Randomized controlled trial. Sao Paulo Medical Journal = Revista Paulista de Medicina. 2021, 139, 6556-563. PMID, 34787294, https://pubmed.ncbi.nlm.nih.gov/34787294. doi 10.1590/1516-3180.2021.0048.0904221. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.